You're sitting in a waiting room. The chairs are the same beige they have always been. A nurse calls your name, hands you a form, and says the word that makes everything feel manageable. Routine. Routine screening. Routine blood work. Routine follow-up. You sign. You always sign. Because the word routine means this is normal, this is expected, this is what careful people do. But here's the thing. After 32 years of practicing internal medicine, the last 18 focused almost entirely on patients over 65. I have watched that word do real damage, not because doctors are careless, not because medicine is broken, but because routine was designed for a body at 50, and after 70, you are working with a different equation entirely, one that almost nobody shows you. Some of the tests your doctor orders after age 70 are more likely to harm you than help you. I want you to understand that sentence, not fear it. Understand it, because what I'm about to share isn't a warning against medicine. It's a warning against the version of medicine that stopped updating its math when you got older. If this is the kind of conversation you've been looking for, the one your doctor hasn't had with you yet, stay with me. Subscribe. Because we're going to have it a lot. Let's start where most people don't expect the danger to be. Number 5. Arrives quietly. It's the prostate-specific antigen test, the PSA, and for decades it felt like a triumph of preventive medicine. A simple blood draw, a number, and if that number was elevated, you acted. You protected yourself. That's what responsible patients did. But here's what the number doesn't tell you. The PSA test cannot distinguish between a slow-moving cancer that would never threaten a 75-year-old's life and an aggressive one that requires immediate intervention. And when you're over 70, the majority of elevated PSA results are the former, a cancer that, in the words of one urologist I trained alongside, you will die with, not from. The US Preventive Services Task Force stopped recommending routine PSA screening for men over 70 precisely because the evidence showed that the cascade it triggered, biopsy, diagnosis, radiation, surgery, caused more measurable harm than the cancers it caught. Incontinence, erectile dysfunction, infection, depression, real losses. In a man who, had he never known, would have lived the same number of years with dramatically better quality of life. I had a patient named Gerald, 78 years old, retired railroad engineer from outside Pittsburgh. His PSA came back elevated at a routine physical. He was scared, so he proceeded. Biopsy, Gleason score, surgery. The cancer was real. It was also slow growing and almost certainly non-lethal at his age. Gerald survived the surgery. He did not survive the complications the same way. He spent the last 4 years of his life managing incontinence and nerve damage. He told me once, quietly, sitting in my office, "I wish I'd asked more questions before I let them start the machine." That phrase has stayed with me. The machine. Once it starts, it is very hard to stop. And that brings us to number 4. This one lives inside the chest, and it's called the low-dose CT scan for lung cancer screening. In a 60-year-old former smoker, this test has real, documented value. The data is solid. But extend that logic past 70, especially past 75, and the math changes in ways that most patients are never shown. Studies published in the Journal of the American Geriatric Society have found that in older adults with significant comorbidities, and most patients over 70 have at least 2, the false positive rate for low-dose CT screening runs between 20 and 40% in the first round. Think about what that means. 2 to 4 patients out of every 10 come back from that first scan with something that looks like cancer and isn't. But they don't know it isn't. So begins the cascade. Follow-up, CT, PET scan, bronchoscopy, biopsy. Each step carries its own risk. Each step deepens the fear. Each step moves a patient further into a system that is designed to find and treat, regardless of whether treatment, at this age, with this body makes sense. The smarter question, and I'll give you the framework for all of these at the end, isn't, should I screen? It's, what happens after, and is my body strong enough to survive what we find? Number 3 is the one that surprises people the most. It surprised me the first time I saw the research, and I had been practicing for 15 years. We're talking about routine cardiac stress testing in asymptomatic adults over 70. This test has become a ritual in geriatric medicine, scheduled with the same casual regularity as a blood pressure check. And its logic feels airtight. You're older, your heart is older, let's see how it handles stress. But the American College of Cardiology has been increasingly clear. Routine stress testing in patients without cardiac symptoms does not reduce mortality in older adults. What it does do, reliably, is generate abnormal findings, because an older heart frequently shows changes on a stress test that are age-related, not disease-related. And once you have an abnormal stress test, the next step is almost always a cardiac catheterization. And catheterization in a 72-year-old carries a stroke risk, a bleeding risk, and a kidney damage risk that are not theoretical. They are documented, they are real, and they are risks you accepted because a test that was meant to reassure you found something that, in a younger body, would have been a genuine alarm, but in yours was just the sound of time. There is a woman I will call Margaret, 68 when I first met her, 71 when this happened. No chest pain, no shortness of breath. Referred for a routine stress test before an elective knee surgery. Abnormal result, catheterization ordered. During the procedure, a small stroke. She recovered most of her function, but not all of it. She lost some word retrieval, some spatial memory. She told me she sometimes forgets, mid-sentence, the name of the street she's lived on for 40 years. A routine test, no symptoms, a cascade that couldn't be stopped once it started. Number 2 carries a different kind of weight, because this is the one built on the most powerful word in medicine, cancer. Routine colonoscopy after 75. The guidelines from the American Cancer Society and the USPSTF both recommend that most adults discontinue routine colorectal cancer screening after 75 and stop entirely after 85. Not because colon cancer isn't real, it is, but because the preparation itself, the bowel purge, causes dangerous dehydration and electrolyte imbalances in older adults at a rate that most patients are never told about. Because the sedation risk is higher, because the perforation risk during the procedure is higher, and because the cancers found in asymptomatic adults over 75 are, the majority of the time, slow growing enough that they will not affect survival, but the procedure used to find them might. What no one says in the scheduling call, at your age, the benefit window for this test has likely closed, and the risk window has opened wider than it was before. Which brings us to number 1. And this one I want you to sit with, because it's the most consequential, and it's the one that took me the longest to say out loud to patients. Routine bone density screening followed by immediate pharmacological treatment in women over 70 with mild osteopenia. Bone density scans are not dangerous. The scan itself is as safe as standing near a window, but what follows, a result showing mild bone thinning in a woman over 70, has become one of the most well-documented examples of overtreatment in geriatric medicine. Bisphosphonates, the standard medications prescribed after a low to moderate DEXA result, carry a rare but real risk of atypical femur fracture with long-term use. Let that land for a moment. A medication prescribed to prevent fractures can, in a small but documented percentage of patients, cause a different fracture entirely. One that is sudden, bilateral, and extremely difficult to repair. Research from the New England Journal of Medicine has shown that for women with mild to moderate bone loss, not severe osteoporosis, the absolute risk reduction from bisphosphonate therapy is often less than 1% over 3 to 5 years. A risk of under 1%. Against a side effect profile that includes jaw necrosis, esophageal damage, and the atypical fracture risk. In mild cases, watch for weighting, resistance exercise, calcium, and vitamin D may carry more benefit than an immediate prescription triggered by a number on a scan. I am not telling you to refuse treatment. I am telling you to ask, is this mild, moderate, or severe? What is my absolute risk reduction with medication versus without? What are the alternatives? Those are not difficult questions, but they are ones that most patients never think to ask because the test happened, the number came back, and the machine started. And that's the framework I want to leave you with. 4 questions. Write them down if you need to. Before any screening your doctor recommends, what will happen after this test if we find something? What is the false positive rate in someone my age? What is the risk of the procedure that would follow? And what is the absolute risk reduction, not relative, absolute, that this screening provides for a person with my health profile? You have the right to ask. You have the right to wait. You have the right to say, not yet, and ask again in 6 months. Knowing that is not the same as refusing medicine. It is the definition of informed consent, the thing the system, in its speed and its institutional momentum, often forgets to offer you. Leave a comment below. Has a screening ever led to more problems than it solved? I read every one. Your story might be the one that changes someone else's next appointment. What I want you to feel right now isn't fear. What I want you to feel is the particular calm of someone who knows something important. The screening math shifted the day you turned 70. Now you know it shifted. Now you get to ask the right questions. And that, more than any test, more than any result, is what keeps people well.